Welcome to today's ADIA webcast titled Protecting Oral Health in the HIV-AIDS Community, Academic Dental Institutions and the Ryan White Program. It's now my pleasure to introduce our host, Dr. Eugene Anderson, who is the Chief Policy Officer and Managing Vice President of the American Dental Education Association. Dr. Anderson leads the ADIA Policy Center, which provides evidence-based research and analysis, collaborative advocacy, and thoughtful leadership. The ADIA Policy Work Center works through the 4 targeted portfolios, including access, diversity and inclusion, advocacy and governmental relations, educational research and analysis, and institutional capacity building. We are pleased that Dr. Anderson could join us and host today's webinar. Dr. Anderson, welcome to the program.
Thank you, Kurt. I want to welcome everyone to our first webinar of 2015. For today's topic, we're fortunate to have Dr. David Resnick as our leading conversation expert. Currently, he serves as the Chief of Dental Services of the Grady Health System and Director of the Oral Health Center of Grady's Infectious Disease Program in Atlanta, Georgia. Thank you, Dr. Resnick, for joining us today. Again, I will be your host, Dr. Eugene Anderson. Today's webinar will focus on the oral health needs of people living with HIV/AIDS and the importance of the Ryan White dental programs. Dr. Resnick and I will discuss these dental programs and the significant role academic dental institutions play in the health and well-being of persons living with HIV/AIDS. During our conversation, we welcome your questions and comments. As Kurt said, there's a chat box at the bottom of your screen. And exclusive for today's participants in an ADIA webinar first, we have an early release of an ADIA Policy Center white paper titled Understanding the History and Securing the Future of Ryan White Dental Safety Net Programs. This white paper is available for download under the document tabs right there in the lower right corner of your screen. So, Dr. Resnick, since the first reported case in 1981, HIV/AIDS has led to more than 600,000 deaths in the United States of America alone. Dr. Resnick, can you please provide a brief overview of the HIV/AIDS epidemic?
Dr. Anderson, it would be my pleasure. Welcome, everyone, to this ADIA webinar. I think we should start off by briefly talking about something that happened under President Obama, which is the creation of a national HIV/AIDS strategy. Until this was created for the U.S., actually all of the grantees for our global program had to have a national HIV and AIDS strategy, but we ourselves did not have one. So the 3 primary goals that we see are reducing HIV incidence, increasing access to care and optimizing health outcomes, and reducing HIV-related health disparities. And there we go. As we know, actually, the new CDC surveillance data came out today, and I will be referencing that, but there are more than 1.2 million people in the United States who have HIV, and almost more than 200,000 who do not know that. Gay and bisexual and other men who have sex with men, or particularly young black or African-American men who have sex with men, are most seriously affected by HIV. By race, blacks and African-Americans face the most severe burden. What is frightening for me, since I've been working in this epidemic almost since the beginning, is that every 9 minutes and 30 seconds there is a new HIV infection within the United States. So we really need to work on our prevention messaging and something more important that we'll discuss today, which is linking and retaining patients in primary care, something that we as a country can do a lot better. I'd like to go over a little bit of the statistics about the infection. When we look at the estimates of new HIV infection in the U.S., some of the points that I'd like to bring out are related to what was released today, the CDC's 2011 surveillance report. This report represents and presents data on diagnosis of HIV infection through 2011, so it's a little bit newer than the slide in front of you, but the same numbers or the same kind of distribution is what we are still seeing. Surveillance data shows that HIV remains a significant threat in the United States. From 2008 through 2011, the annual estimated number and rate of diagnosis of HIV infection among Americans remained stable in the U.S., yet in 2011, an estimated close to 50,000 Americans were diagnosed with HIV. This is far, far too many. As evidenced by previous reports and in the data that we have in front of us today, HIV continues to have a devastating toll on Americans, particularly men who have sex with men and racial and ethnic minorities. Men who have sex with men represent 2% of the U.S. population, but 62% of all HIV diagnoses are attributed to male-to-male sexual behavior. African Americans represent approximately 12% of the United States population, but 47% of diagnosis of HIV infection. Latinos account for 16% of the U.S. population, but 21% of the HIV diagnosis. So we can see this disproportionately affecting minorities and men who have sex with men. And my computer's taking a moment. I'll be right with you as I try to move to the next slide. Here we go. This is something that is remarkably important to discuss. It's called the CDC's Continuum of Care, the HIV Continuum of Care, and this is as of 2011. So what the chart in front of you represents is that 86% of the people who have HIV infection within the United States know their status. Now, if you looked at what I previously talked about in the National HIV/AIDS Strategy, we really wanted to get a higher percent of people to know their status. So we still have work to do there, and there is a role that dental offices can play in helping identify people with HIV. Where we really have a problem is the number of people who receive medical care. If you notice that significant drop-off, so linkage into primary care is vitally important. Then there's a smaller drop-off to the patients who are prescribed antiretroviral therapy, and then those that are virally suppressed is about 30%. Now, why is that so important? There was a study several years ago, HPTN 052, that looked at serodiscordant heterosexual couples, and they found that when the HIV-infected partner was virally suppressed, there was a 96% reduction in transmission. What we found out from recent reports is that 90% of all new infections come from people who are not either diagnosed or in care. So it's very important that as a country we get that viral suppression number up, we get the people prescribed ART up, and we get those who are staying in medical care to go up. Another important slide from the dental perspective, if only 30% of those patients have undetectable viral load, one of the signs or one of the things that we look at for oral lesions that we see in association with HIV is the detectable viral load. So we're still seeing the lesions that we saw earlier in the epidemic, just not quite to the point. I would like to bring up another remarkable value of the Ryan White HIV/AIDS programs. When we look at patients who receive their care at Ryan White primary care centers, up to 70% have a suppressed viral load. So our federal tax dollars are doing a great job when it comes to managing patients with HIV and AIDS. We just have to get more patients into those centers and more people to take their medicine and get better outcomes.
So, Dr. Resnick, you mentioned the connection between oral health and persons with HIV/AIDS. Can you say a little bit more about the oral health needs of the HIV/AIDS community?
I'm sure, Dr. Anderson. Why don't we ask the audience a related question? What percent of people living with HIV and AIDS will experience at least one major HIV-related oral health problem? And this is a poll, and I think Kurt will help get us through the poll.
Certainly will, and the audience is already responding. You simply click on either the radio button or the color box to indicate your choice of either 20%, 46%, or 83%, and we'll give everyone just a few moments to complete that, and maybe another 10 seconds or so, then we'll go ahead and stop the poll and share those results, and then look for a comment from you, Dr. Resnick. So last call, about another 5 seconds, if you would, please. And it's like maybe some of the responses are shifting between a choice and another. With that, we'll go ahead and stop the poll. Thanks for your participation with that. We'll share the results. And Dr. Resnick, 54%, the majority of the group that responded to 83% as the answer. I'll turn it to you for your comments.
Well, that was the case before we had these major advances in combination antiretroviral therapy, where just about everybody who was living with HIV would present with an oral lesion. Actually, today, the number is closer to 46%, so that is actually our correct answer. And what is the importance of oral lesions? Well, they're common and easily evaluated. They can indicate early HIV infection, but it's important to point out that there are no oral lesions that are diagnostic of HIV. For some reason, if a patient presents with candidiasis, it could be uncontrolled diabetes. They could be on a steroid-containing asthma inhaler. There are other reasons. Oral hairy leukoplakia, recent research has been associated with use of those steroid-containing asthma inhalers. So there are no lesions that are diagnostic of HIV. They should be treated. Some are painful. Some are cancerous, such as Kaposi sarcoma. Others are things like oral warts that we've seen an increased incidence of over the last several years. As a matter of fact, a study was just released recently that showed that patients who have a CD4 count less than 200 were significantly more likely to present with oral warts, which is a manifestation of human papillomavirus. They can be a feature of progression. Doing an oral soft tissue exam is remarkably important on all patients, and especially in this patient population. They are used in staging systems. They could be progression independent of CD4 count, of disease status. They correlate with viral load. Those who have undetectable viral load should not present with candidiasis, and they're an indication to change certain treatments. I mean, we've had cases in here where a patient decided that she actually wanted to stop therapy several years ago when the therapies were more toxic, and everybody tried to talk her out of it, including myself, and when she came back several months later for a routine hygiene visit, she had moderate to severe candidiasis and actually ended up in the hospital with a mild case of pneumocystis pneumonia, the AIDS-defining pneumonia. Had she not come here, had we not linked her into care, chances are this patient could have died. So for people living with HIV disease not yet on therapy, the presence of certain lesions such as candidiasis may signal progression disease and time to start therapy. For patients who are on therapy and who should have undetectable viral load, if they don't have undetectable viral load, we're more likely to see these lesions. And when you do soft tissue exams on any patient that would come into your office and you see something like I'm getting ready to show you, such as candidiasis, oral hairy leukoplakia, and erythematous candidiasis, a referral to primary care after we address the lesions is remarkably important. The examples we have here of candidiasis, those are mild cases of candidiasis and can be treated with a topical, such as clotrimazole. Oral hairy leukoplakia, on the other hand, related to HIV, the best way of treating that is getting the patient on a good antiretroviral therapy. So we have a patient that walks in the office that doesn't know their HIV status, and they have an oral lesion. What are some of the things that you can do? A referral is fine. One of the things that we're finding is due to the stigma associated with HIV, many patients actually don't go to that referral, don't get tested. So there was a study back based on the 2005 National Health Interview Study, authored by Harold Pollack, et cetera, where an estimated 3.6 million Americans reported they are a significant risk for HIV, yet have never been tested. 3/4 of those people had seen a dental health care worker within the past 2 years, and their conclusion was these dental visits represent missed opportunities for HIV screening. So we can screen, we can offer tests in the dental setting, setting. That's been done in several places throughout the United States, including ADIA member locations such as the University of Maryland and NYU and Sheridan Dental Hygiene College out in Sheridan, Wyoming. Or we can actually screen on a broader sense. So there was a study that was done by NYU, and they looked at, and they're the largest provider of dental health care in the city for uninsured or underinsured people, revealed that 74% of those who were approached would accept HIV screening. The fact that it was coming from a dental office didn't really matter, whether they got the results from a dentist or a nurse or a primary care provider. So there are many things that we can do. We can monitor disease status, we can check for disease status, and of course, most importantly, we can bring people to oral health. And that's one of the wonderful things that the Part F dental programs and other parts of Ryan White have offered to our patients since the legislation was funded in 1991.
David, can you tell us about the barriers facing the HIV/AIDS community when it comes to accessing dental services?
Sure, Dr. Anderson. There are several, and many of them are very similar to barriers that similar to barriers that exist in the general population, such as cost of care or access to care or fearing dental care or not knowing its importance. And then there are issues such as that are very unique to this patient population, and the number one is issue becomes stigma, the fear of disclosing their status, or since there are not a great deal of programs that are set up outside of these Dental Education Association programs and Ryan White programs, there could be long delays before appointments or long time in the waiting room. For children, there are specific issues that might deal with parents, caregivers, or caregivers' dental fear and low prioritization of dental care. But the biggest one that we've really seen is the stigma-related concerns, which regretfully even today is driving this epidemic. I wanted to bring out another point is the shortage of dentists trained and willing to treat patients with HIV and AIDS. I run a Lutheran Medical Center residency program in Atlanta. And like most of the residency sites, we get a lot of applications, and the majority of the applications on why do you want to do this is lack of experience managing medically complex patients, and that's something that is enormous. Now, due to the Part F dental reimbursement program and community-based dental partnership program and efforts through the AIDS Education and Training Center, we have made great strides in changing the attitudes of dental health care workers when it comes to managing this patient population. But through these dental programs, especially these Part F dental programs that we're referring to today, we have done a remarkable job of training our generation and the next generation of providers on how to manage this and other medically complex diseases. Maintaining these programs, funding these programs appropriately is vital to ensure that the dental workforce in the future can manage this disease as well as others. We talked about dental anxiety and fear, lack of dental insurance coverage, or where you do have coverage, it's minimal at best. Many of the patients that we'll get to later who access care through Ryan White are within 100% of poverty. And since adult dental Medicaid benefits are optional services, not mandatory Medicaid services, a lot of times they get cut when states are trying to get their balanced budgets together, and to me that's actually more than a shame, it's a sin. It's also important to point out that Medicare is not a source of general dental coverage for adults. Veteran dental care benefits and VA dental care eligibility are based on a number of factors, including service-related disability, and HIV is not considered a service-related disability. Therefore, a lot of VA patients are in need of referral to an outside dental program, such as the one that I run or the Boston program or many of the other excellent programs throughout the country.
Dr. Resnick, about 15 years ago, having HIV/AIDS was synonymous pretty much with a death sentence. But today there seems to be a notion that there's a treatment, almost like a cure. Can you explain where things stand now?
Well, the hunt for a cure is still elusive, although the NIH is putting a great deal of research dollars into looking for a cure, as are other research institutes, both in the United States and abroad. But we have come a long way. When I first started seeing these patients in the mid-'80s, HIV was a death sentence. There was no question. And as the chart that you see in front of you shows, in 1995, the U.S. death rate for HIV actually decreased down to 67%. That coincides with the onset of what we have today known as the HIV cocktails, or more appropriately known as the combination antiretroviral therapies. Also during the period of time between 1995 and the 2008-2009, we saw new classes of drugs being developed that were very potent. So we can get viral suppression, which would help keep the patient healthier and able to live as long as anyone who doesn't have HIV infection. But as we saw earlier in the presentation, regretfully, there's a large number of patients in the United States who are not accessing these medications and who do not have undetectable viral load. But when I can tell you from just general experience in treating this patient population and research studies that have been out there for years, it is no longer a death sentence, but it still has the stigma associated with it like it did in the earliest days of the epidemic. So we still don't have a cure. We're working towards a cure. There's medications that are now being used to help prevent people from getting HIV. It's called pre-exposure prophylaxis. There has been only one, in the last 14 years, there's been only one healthcare worker, no dental healthcare workers, who is actually seroconverted after an exposure in the work setting, and that was a lab technician. As long as we have our post-exposure prophylaxis systems ready to go, there should be no issue, because we've never had a documented case of a dental health care worker seroconverting after an incident in the dental setting. There's a question that sort of popped up on how would I suggest encouraging new and experienced dentists to help with treatment of HIV and AIDS patients. One, it's actually against the law, the Americans with Disability, to turn a patient away based on HIV status alone. I basically go out and I've been blessed to be able to lecture all over the United States and a few other places, and I basically at one point in my lecture say I'm considered an expert in HIV dental care, and I do nothing different than what you do on a daily basis, hopefully as well as you do.
Thanks, David, for answering that question, and we'll have some more questions from our audience later in the webinar. So for any listeners who have recently joined today's webinar, welcome. Our topic today is protecting oral health in the HIV/AIDS community, academic dental institutions, and the Ryan White program. The webinar is being presented by the ADIA Policy Center, which supports ADIA's role as the voice of dental education. I'm your host, Dr. Eugene Anderson, the ADIA Chief Policy Officer and Managing Vice President. To learn more about the ADIA Policy Center, we encourage you to visit the ADIA website, www.adia.org, and click on the Policy tab. Be sure to stay connected with us as we continue to share more information about ADIA's policy efforts. Joining us today is a leading expert in this topic, Dr. David Resnick. Before we continue with our discussion, now is an appropriate time to get a count of how many people are participating in today's webinar. Kurt?
Thank you, Dr. Anderson, and we completed that poll while you were reviewing the information about ADIA, so I think at this point we can move on.
Okay. Dr. Anderson?
All right, great. So for the first part of the webinar, we heard from Dr. Resnick about the HIV/AIDS epidemic, the oral manifestations of HIV/AIDS, and the role dentists and dental schools can play in addressing the unique oral health needs of people living with HIV/AIDS. Now let's hear about the Ryan White HIV/AIDS program, which is the nation's largest program funded exclusively for low-income, underinsured, and uninsured people living with HIV/AIDS.
And Dr. Anderson, Ryan White was actually diagnosed with AIDS at the age 13. He and his mother, who continues to this day to champion the cause based on her experience and all of the people she's met around the world, Jeannie White-Ginder, fought for his right to attend school. It gained international attention and became a voice of reason about HIV and AIDS. At the age of 18, Ryan White died on April 8, 1990. Just months before Congress passed the AIDS bill that bears his name, the Ryan White, it was originally known as the Ryan White Comprehensive AIDS Resource Emergency Act, otherwise known as the CARE Act. On August 18, 1990, by wide bipartisan margins, both houses of Congress worked together and came up with the groundbreaking Ryan White CARE Act. It was named for this Indiana teen who lost his life to AIDS. By the time the bill was law, more than 150,000 U.S. AIDS cases had been reported and more than 100,000 had died. So let's talk a little bit about the Ryan White program. It's actually divided into 5 parts. Part A, referred to as emergency relief for eligible areas, actually targets the metropolitan statistical areas that are hit hardest by the epidemic. So Boston, Atlanta, Philly, Washington, D.C., which has an enormous epidemic, San Francisco, Los Angeles, etc., all receive funds from Part A. Part B are funds that go to states and territories, all of the states and territories. The largest part of Part B includes the AIDS Drug Assistance Program, commonly referred to as ADAP. That makes these medications available to these low-income, uninsured or underinsured people living with HIV and AIDS. Part C go to primarily medical centers, community health centers around the United States, and these are for early intervention services. They do diagnostic work as well as manage the disease. Part D, which is a very important part of the Ryan White HIV/AIDS program, specifically serves women, infants, children, and youth. Last year during the budget discussions, we actually had to fight have a battle, basically, because there was a wish from some people in the administration, primarily from HRSA, to merge Part C's and D. As someone who works in a program that has Part D funding, it is vitally important that women, infants, children, and youth have their own special funding source to meet their own special needs. It's been remarkably successful since day one, also has bipartisan support. Part F is what we're focusing on today, and that includes the dental programs, which I'll mention in a moment, and the AIDS education and training centers, which are undergoing a rebid process now. They're located throughout the United States, and they primarily target, at least in the past, have targeted what they consider the Big Six, and included in the Big Six are dentists and dental hygienists. They also train dental assistants, physicians, nurse practitioners, nurses, pharmacists, and other advanced practice providers such as PAs. The SPINS program is referred to as Special Projects of National Significance, and this program actually does research to find models that work and better ways to engage populations. There was an oral health initiative that SPINS ran, and I actually do recommend that today's participants take a chance to look at the Oral Health SPINS project that was published in a supplement to public health reports. The CARE Act is one of the only few disease-specific health programs in the country, and right now it is actually not reauthorized because with issues surrounding the Affordable Care Act, people haven't been comfortable with reauthorizing a disease-specific group, although it does maintain its funding. And I think it's important to point that out. Also, we do not have enough data as to the positive impacts that the Affordable Care Act is having on our patients. The 1990 legislation required that people living with HIV and AIDS be involved in implementing Part A program for eligible metropolitan areas through planning councils. Consumers were also involved in implementing Part B programs for states and territories. And getting consumer involvement to make your programs better is always a key feature on a performance improvement project. It is very important to point out that the CARE Act is a discretionary budget program. Unlike Medicaid and Medicare, which are entitlements, the Ryan White CARE Act actually has to be funded on an annual basis. The availability of funds is contingent on the federal budget. So many people who do national advocacy around HIV and AIDS keep a close eye on the budget, and actually friends of mine are on the Hill today talking about the importance of Part A and other parts of the Ryan White CARE Act and how they need to be funded. The CARE Act intent is that funds be used to serve people living with HIV and AIDS who are low income or underinsured or otherwise lack the resources to access services on their own. Thus, the CARE Act was and still is the payer of last resort. Funds could not be used to supplant other resources. When we look at the services, when Ryan White was reauthorized in 2007, 75% of the funds were for Parts A, B, and C had to be used towards what we call core services. And the core services are included oral health care. If I were actually made the slide, I would have made oral health care much bigger, primary care, medications, mental health and substance abuse services, and medical case management and treatment adherence counseling. Other services as food, transportation, peer counseling, translation, which are vital to keeping people in care and helping providers provide the care, are considered support services. The majority of the patients that we follow are below 100% of the federal poverty level. 6 in 10 of the patients that we follow had incomes below 100%. 19% had incomes, between 101 and 200% of poverty. 3 in 10 clients were uninsured, but most had some kind of other insurance and are considered underinsured, or they're covered by Medicare, Medicaid, private insurances, which is very small, and other sources, but face limits in their coverage or need coverage completion. Clients are largely male, between the ages of 45 and 64. I believe this year the estimate is that more than half of the epidemic will be 50 years or older, and the majority are also people of color. 4 in 10 clients were gay or bisexual men. So it's estimated that Ryan White served an estimated 536,219 clients in 2012. 68% were male, 31% were female, and 89% were between the ages of 25 and 64. Black or African Americans represent 47% of the Ryan White HIV/AIDS program population, followed by whites at 28% and Hispanics at 22%. And one of the things that we really need to do is to focus on the support for these programs, because they've been around for a long time, yet many people don't know that they exist. And the HRSA grantees need to hear from us. People on the Hill need to hear from us. But let's talk about these programs and discuss them. There are 2 main programs that were basically addressing the fact that in the earliest parts of the epidemic, we needed to get dental health care workers trained at an early age to be comfortable with the patient population. You can go to as many didactic lectures as you want, but actually being with a patient who lives with HIV and AIDS teaches you more than any one person's didactic lecture could ever give. So have experience in treating the patient population in the undergraduate dental education or dental hygiene education or postgraduate dental education is vital to ensure that we have this that the providers to work on people when someone like myself is retired. So the dental reimbursement program provides direct care to our patients. Community-based dental partnership is a little bit different, but people ask about what are the limitations. HRSA does not give us any limitations on the kinds of scope of service that we provide. So if you're a program that does implants and you want to do implants, you can. If you're a program that does crown and bridge and partials and periodontal care and all those different things, there are no defining limits on what you can do. It does increase the awareness and importance of oral health care for people living with HIV. It teaches and trains dental students and dental hygiene students and dental residents to properly care for and treat the unique needs and conditions of people living with this disease. And it coordinates with other HIV/AIDS programs, which is truly important. Because many of these programs actually do get funding from other parts of Ryan White. The dental reimbursement program was first funded in 1994. It assists accredited dental or dental hygiene education programs by defraying their unreimbursed costs associated with providing care for people living with HIV and AIDS. But one of the problems that we're finding is, and we'll discuss this more, is that the amount of money given to the dental reimbursement program has stayed flat for the last several years, and that doesn't even take into consideration sequestration, yet the cost of care have gone up, and many grantees report that their unreimbursed costs continue to rise. So that is actually quite a problem as we're facing declining reimbursement rates, and we want more programs to get involved so more dental students, dental fellows and residents and hygiene students can participate in the program. Excuse me. So I think it's time maybe, excuse me 1 second. Actually, what I'd like to do, Dr. Anderson, if it's okay with you, is pose a question to the audience about the reimbursement rate for dental grantees.
Please, go right ahead.
So the dental I want people to take a guess on what level of reimbursement of uncompensated cost our grantees received in the last year.
And as before, either the radio button or the color box will record your choice. It looks like they're coming in quite quickly, Dr. Resnick. We'll give everyone perhaps another 10 seconds or so to complete that, and we'll share the results and look for your comments on how they responded. Questions, as you are aware, can be submitted through the general chat at any time. You can see many have been, and we do encourage you to submit your questions and comments. Both are certainly helpful in the discussion of today's topic. At this point, we'll go ahead and stop the poll, and let me then share the results. And it's a very close one percentage-wise. 41% chose the 26.1 option, 40% 46.7. With that, I will turn it back to you for your comments.
I wish the second choice were the correct answer, and even that wouldn't be sufficient to cover the cost of the care that's provided. Regretfully, we are down to 26.1% of coverage of non-reimbursed funds, with a total cost of $32,387,000 in non-reimbursed costs. That's just frightening. If we don't get the academic institutions involved and people who are on this call and other national organizations to look at this program and say we have to do better, because schools will drop out and then we won't have the providers available in the future that are actually going to be able to care for this patient population and other medically complex patient populations. So regretfully, the answer was 26.1%, and that's just awful. Let's talk about who the grantees were. There were 56 applicants eligible funding. Award recipients were located in 22 states plus the District of Columbia. Grantees trained over 11,700. That number, 11,700 dental students, postdoctoral dental residents, and dental hygiene students, providing oral health services to over close to 40,000 HIV-positive patients. For someone who started before there was a payer source, this is close to being a miracle, that people are still this engaged, that they're managing, that we're training close to 12,000 dental health care workers in our future, and that close to 40,000 patients are receiving care. Of the award recipients, 29% were pre-doctoral dental education programs, 39 or 70% are postdoctoral dental education programs, and 2% is a dental hygiene education program. That actually was added to the law during one of the last few reauthorizations. The dental hygiene institutions could seek these funds, and today we only have one. So for my dental hygiene colleagues on the phone, we can do better. Actually, we must do better. We have to get our dental hygiene colleagues involved. For a moment, I'd like to talk about the Community-Based Dental Partnership Program, and I've had the honor of visiting several of these programs around the country, and actually we'll be visiting a few more in the upcoming year. This is unique in that these partnership programs are between accredited dental education centers and institutions and community programs, and they're definitely designed to address community needs. In many cases, they get dental students or dental hygiene students or residents out of the dental setting into the community, and that has a remarkable impact on their knowledge moving forward when addressing this patient population. The Community-Based Dental Partnership Program was first funded in 2002 to increase access to oral health care services for HIV-positive individuals while providing education and clinical training for dental care providers, especially those in community-based settings. So this one actually does outreach to the dentists that are in the community, licensed dentists. To achieve its goals, the Community-Based Partnership works through multi-partner collaborations between dental and dental hygiene education programs and community-based dentists and dental clinics. Community-based program partners and consumers are integral to the design of these programs and their impact. There were 12 grantees, and due to flat funding, we have never actually been able to increase the number of grantees for the Community-Based Dental Partnership Program. And again, this is a remarkably successful program that has models that can be replicated in different parts of the United States, but due to flat funding and we need greater advocacy around this issue, we should be able to increase that number. They're located in 11 states. Grantees trained 3,000 dental students, postdoctoral dental residents, and dental hygiene students in HIV oral health care, providing oral health services to over 5,800 patients, which is pretty remarkable. There were, one more. Excuse me 1 second, I'm sorry.
Well, Dr. Resnick, let me ask you a question. We received a question about funding. So can you tell us at what levels are dental programs funded?
I can, and there's a slide in front of you at this point that looks at the Ryan White program, which for the most part, if you look at FY13, that's sequestration numbers. That's why there's a drop in both what the Part F dental programs received as well as the overall operating budget for the Ryan White programs. We see an increase, a small increase in this year's budget from the president. It was not targeting Part F, but rather targeting Part C, the early intervention services. And so we as a community are asking for close to a $5 million increase for Ryan White Part F. For those who are on the call, for your relatives, for your patients, have them call your person in the House of Representatives and your senators and say, we need this. $5 million in today's budget is basically the equivalent of, I hate to use the phrase, but it's budget dust. It's nothing. but it would make a huge difference to the accredited dental education facilities that have been providing this care for numerous years, as well as for the community-based dental partnership programs. And if we can at one point get our dental reimbursement program up to a reasonable level of reimbursement, then we can look towards increasing the number of the community-based dental partnership programs.
David, can you give a brief overview of the potential impact of the Affordable Care Act on the Ryan White HIV/AIDS programs? We hear a lot in the news today about the Affordable Care Act. How does it potentially impact these programs?
Well, for people who are living, and you have a slide in front of you that sort of shows where the epidemic is, how or where it's heaviest in today's burden. But for people who are living in states like Massachusetts, which have Ryan White funding and also have Affordable Care Act funding through Medicaid expansion, they do have a high burden of disease, but their level of undetectable viral load is significantly higher than states that don't have Medicaid expansion. So it's the combination of what Ryan White can do and what the full implementation of the Affordable Care Act will do that gives our patients the best chance for the best outcomes. For us to get that 30% in non-Ryan White programs who have achieved viral suppression and get that number higher, because every time we get that number higher, we're going to reduce the number of new infections and we'll get this epidemic under control. It's regretful to say that all these years after the beginning of the epidemic, we still don't have the epidemic under control. So if you look at the current status of state Medicaid expansion decisions, you can see that where the epidemic is really hitting hard, which is in the southern United States, there are no plans at this point of adopting Medicaid expansion. And regretfully, we have created, to a certain degree, almost two Americas, where there is better access to medical care in the Northeast and the West and in places like Colorado and New Mexico, and then states like my own in Georgia, where I'm actually dental director for the Southeast AIDS Education and Training Center presently, where none of the states, the only one that's considering adopting Medicaid expansion is Tennessee. None of the states that we serve where the epidemic is hitting the hardest are considering Medicaid expansion at this point. So we need every one of those Ryan White dollars just to provide basic core services for our patients. The combination of both gives a great outcome. Ryan White has not been reauthorized today because we need more data like coming out of Massachusetts to show how well these programs work together, show the number of people that do have insurance. Of course, there are some compounding factors like the Supreme Court decision we're expecting in June, but even with full implementation of the Affordable Care Act, the Ryan White programs will be necessary. You can look at some states who've done Medicaid expansion are granting some comprehensive dental care. But if you look at the dental care that's offered in most of the states in the Southeast, it is very minimal, possibly emergency care only like in Georgia, to some basic preventive work. So we're going to have our hands full trying to ensure that Ryan White stays funded and that the Affordable Care Act is implemented.
Thank you, Dr. Resnick. Certainly much more work remains to be done. We're going to turn now to some questions from our participants. So, Dr. Resnick, I want to ask you, one of our participants asked, how can we get more support for community outreach and increased education on HIV/AIDS and oral health?
Well, that would be, there's multiple ways of doing that. You can partner with your state AIDS Education and Training Center, which puts on these presentations. I honestly was scheduled to be in Nashville today, but due to weather couldn't get there, and we had presentations set up for, a webinar set up for practicing dentists in the state. We had meetings with consumers, with the people who are providing the funding. So we really need to make sure that our experienced dentists who didn't have the chance to work under a Part F dental program and gain that remarkably valuable experience, that they can be trained through the AIDS Education and Training Centers, which is a part of Part F. There are other resources available. A little plug for HIVdent.org, which has resources available, as well as the Facebook page for HIV Dent. So there, how would I encourage people to treat? At one point, I was a private practice dentist in the Atlanta community, and there was a lack of dentists, or were a lack of dentists that were willing to provide care. I can honestly say that my decision to open this program at Grady Health System was the smartest thing I've done in my career. Never have I dealt with a patient population that is so grateful for the care, that is so easy to treat. And in working with our residents, I think they would say the same thing, and they get to learn how to manage not just HIV disease, but also diabetes, hypertension, hip replacement patients. I mean, the importance of continuing the support of the Ryan White Part F programs can never be overstated. It's a remarkable teaching tool, and then the AIDS Education and Training Centers can get to those dental healthcare workers who have not had a chance to participate in one of these incredible programs.
Thank you. Dr. Resnick, one of our participants asked the following. They said that they are in a clinic that does not accept insurance payments. Patients are required to pay out of pocket to receive treatment. So they want to know, how does the Ryan White program work in this kind of situation? Would an HIV/AIDS patient have part or all of their costs paid for through the grant?
Well, that clinic is actually creating a barrier for all patients to obtain care if you're asking for cash first and not utilizing insurance. But the way the dental reimbursement program works, it's a percentage of the uncompensated care from the previous year. And so Ryan White is not an insurance by any stretch of the imagination, and Part F is not an insurance. So I think part of it would be if you have residents at the program and you want to apply, then you could charge them the amount and and provide the service, and then you will get the following year a percentage of the uncompensated costs. Okay.
Another question, Dr. Resnick. Can international dentists participate in this program?
The Ryan White HIV/AIDS program is specifically for the United States and its territories. So regretfully, this program is limited, and we can barely, as you saw from our funding amounts, the percentage has gone down to 26% of uncompensated care. That's not even enough for the accredited dental education facilities, institutions in the United States. I am unaware of a program that's similar to this in different countries, although there should be one, because this is a model program for the world.
Thank you. And our final question, and let me just choose the final one. So I'm sure you're not surprised to hear that many dental schools are frustrated with the very low reimbursement rates and are dropping out or potentially dropping out of this program. Any chance that the reimbursement rate that you talked about earlier will increase?
That is up to each and every person on this call. That is up to by contacting your members of Congress saying that these programs need this close to $5 million increase, so the reimbursement rate goes up. ADIA does a wonderful job of advocating on Ryan White Part F's behalf in Congress. The HIV Dental Alliance also takes a message to Congress. But to be frankly honest, we need everybody and your friends and dental schools and students. If you start, one of the issues with Ryan White when I've been on the Hill, my experience is, well, one, a lot of the staffers are very new and don't know the history and don't know anything about it. But the other thing we hear is that they're not hearing from their constituents about the importance of these programs. So if the people on this call would take a simple moment to contact their senators in Washington, D.C., and contact their individual House of Representative member and say the importance, and we need this $5 million to enable us to stay with this program and continue providing this excellent learning environment and care for this patient population. That's what's going to make the difference. ADIA is a leading voice and is remarkable, and I've had the pleasure of working with folks in ADIA these last few weeks, and it's been a truly exceptional experience. But that's just one voice. And they have also other important missions, such as funding the NIDCR, and other things around dental education, which is equally as important. We need the National Dental Association, the Hispanic Dental Association, the American Dental Association, the Dental Hygiene Associations, but the individuals themselves, people on this call, to call your congressmen, your senators, and say, this is an important program. We may have to drop out because the reimbursement rate is just too low.
Thank you, David. Any final thoughts as we wrap up today's webinar?
I'm honored to have the opportunity to speak on behalf of these incredible programs. We do need your voice to hit the Hill just by making a simple phone call or sending emails. Let them know how important and special these programs are, since there's nothing else like it, even in our legislation. There's nothing else like these Ryan White programs. Talk about the Part F dental reimbursement program. Use that awful number of 26% of uncompensated cost, and let them know it's about 60% to break even, and how asking for a small increase, since we've had no increase in several years, will really, truly not only help out our patients, which is our primary concern, but will also help ensure that continuing education is provided to our undergraduate, postgraduate, and dental hygiene students. That is what's so important. Because when I'm long and gone, there might be a new disease. And based on this model, we figured out how to manage a medically complex patient population safely in a general population. No reason to separate, nothing all that special. But when the next thing happens, God forbid, we need to have systems like this in care. And this disease is not over, as you heard early in the epidemic. 50,000 new infections every year, predominantly hitting, greater than 40% hitting young African-American males. We have got to do something as far as ensuring diagnosis, linkage, and retention in care. So for my program, you can't access a dental program unless you've seen a primary care provider within 6 months. We want to make sure that our Ryan White numbers and the national numbers are closer to our Ryan White numbers, which are 70% virally suppressed.
Well, thank you, Dr. Resnick, for leading this month's webinar and providing your expertise. I want to thank everyone for joining us. And before I turn it over to Kurt for final comments regarding CE, I want to remind everyone of the ADIA Policy Center white paper that is available using the document download option, or at the ADIA website, www.adia.org, under the Policy tab. I also want to tell you about an event that ADIA has in April aimed at doing just what Dr. Resnick talked about, advocating for this and other important oral health initiatives on the Hill. It's ADIA's 2015 Advocacy Day on Capitol Hill, co-sponsored with the American Association for Dental Research. It's April 14th this year, 9 a.m. to 5 p.m. So please, you can contact us directly to find out information about how you can participate. And with that, I'll turn it over to Kurt.
Thank you, Dr. Anderson. And that does conclude today's presentation, Protecting Oral Health in the HIV/AIDS Community, Academic Dental Institutions and the Ryan White Program, brought to you by ADIA and presented by Dr. David Resnick. Your ADIA host was Dr. Eugene Anderson. We do hope everyone enjoyed the presentation. CE is available for this presentation. To obtain CE, enter your name in the site roster that will appear momentarily as we conclude the event. You will receive an automated email with a link to the evaluation and a link to the certificate manager. Complete the evaluation form, and then you may retrieve your certificate. Again, you'll be redirected to the site roster as we conclude the presentation. And be sure to follow ADIA Web on Twitter to join the conversation using the hashtag RyanWhiteDental. You can find the recording and presentation of the program at www.adia.org/RyanWhiteDental, which will be posted 1 week from today. Today's program is copyrighted in 2015 by the American Dental Education Association, all rights reserved. Thank you all so much for joining us today, and enjoy the rest of your day. The online site roster will appear now.